So we did a bit of work over here. This is a mid-thoracic region of the spine. And can you see okay the specimen here? So what we did is we put 4 screws above the area of the planned unblocked resections and 4 screws below the planned area of resection. We then are going to put a temporary rod on one side. Let's go ahead and put one rod over here. And what you can see here is we did a laminectomy here. And here's the spinal cord right over here. We ligated 2 nerve roots. Here's the nerve roots right here. Can you see that? So here is one nerve root right here. The pedicle is here. And we, in essence, we assume now that this is, let's say, a sarcoma that involves just the vertebral body. There's no extension into the canal. There's no extension into the pedicle. And the idea is to make the cuts through normal bones and separate, just like Dan have explained in his talk, the idea is to separate the tumor around the spinal cord. So we remove the back portion of the spine through a laminectomy, bilateral facetectomy, and actually bilateral pediculectomy. And the tumor is still right here. So you can see here is the vertebral body, here is the disc below, and here is the disc above. So a complete facetectomy bilaterally, complete pediculectomy bilaterally. The proximal portion of the rib has been resected. You can see the pleura right here and the pleura right here. So the rib has been resected to allow us to get to the lateral aspect of the vertebral body. Okay. So go ahead, cut this. Yeah. So you can see that by removing the rib on either side, that gives us access, and disarticulating the rib, that gives us access to the lateral aspect of the vertebral body. So here is the lateral aspect of the vertebral body. The nerve roots have been ligated. The pedicle is flushed right here. The facets has been removed. And so now, what I typically do is I use some sort of a blunt dissection. So, Peter? What's Peter with? You can see, so we can really get around the vertebral body, and you can see it's already start moving a little bit. So, Peter, put your finger just this way, the other way. Yeah, but don't cover the, just kind of put it like that. Yeah, so you can see how gently you can separate the big vessels. Can you feel my finger on the other side? Yeah, so both fingers can then touch each other. And what we're doing really is we separate, assuming again that we have a primary bone tumor in this vertebral body. What we do is we separate that vertebral body from all the posterior elements completely. We separate it from the adjacent ribs to the point that by the time we're doing our discectomy, here is one disc over here. Let's see. Yeah, here is, you can see there is the superior disc on this side. Here is the superior disc over here. Let's just get this removed like so. Just get this. So you can see right here again, here's the disc here. Right over here, that's the superior disc. On either side, we start doing discectomy on this side. Here is the inferior disc on this side and on that side. The pleura has been dissected on either side. The ribs have been disarticulated, and what you're left with is just a vertebral body. And the idea is to complete the discectomy all the way through the ALL. And typically what I do, which I don't have here, but we can put a malleable retractor that goes from this side all the way to the other side, that goes between the big vessels and the vertebral body. And once we can get it all the way to the other side, you can continue your discectomy all the way down and literally separate this vertebral body and take it out from the back end. Now, obviously, this is a very destabilizing procedure. So we have a temporary rod on one side that we can put to hold the spine together. So let's cut the rod here. What is the cutting? And you may have to, it just depends on how it goes. Hold on. Yeah, so we can put a temporary rod on one side here. Maybe put it on your side. Let's put it here. Let's cut the rod here, this side. Yeah. But you can see how nice now the vertebral body is being separated from the underneath vessels. I can put both my fingers and really feel underneath that everything is separated. And then through a discectomy, separate the vertebral body. I'm going to put this temporary rod here. Let's put it here. Yeah, let's just put it here. Yeah, you got some screws? Yeah. So here's the temporary rod goes in here. Let's put one, you got we need a reducer for that. Now I put this temporary rod even before we start doing a lot of the resection itself. Go ahead. So let's bring the floor for a second so we get a feel of what's going on here. All right, can you kind of bring me over here? Okay. Okay, so we can see right here the disc below. My chisel is right here in the disc below. And then you can see it actually in the actual anatomical specimen where we are over here. Again, this is what we're going to do our discectomy through this disc base, and then here's the disc above, somewhere over here. Let's see. Go ahead on. So here is the disc above. You can see we're pretty much already almost to the front here. And so that's the next step. The next step would be to complete the discectomy. Take the floor down. So clearly you got to be very careful with the spinal cord. And there are many ways to do the discectomy. Some can use wires. I typically start doing a discectomy on either side. And I can then sneak that wire underneath and complete the discectomy by walking on either side and just go all the way through. The other option is just take your time and do the discectomy. The difficult part is really cut through the ALL in the front. And again, we have this large malleable that we drive from here, bend it underneath the vertebral body. It's going to come up on the other side. And that's going to be a solid protector between the vertebral body and the big vessels, so you can actually continue your vertebral body resection. So Peter, go ahead and take the pituitary forceps and start doing the discectomy on your side. We have some pituitaries. Let's see, we had something here. Yeah, right here. So go ahead and start working the discectomy. So we're going to start doing discectomy on both sides. Just be very aggressive with it. You want to take the outside aspect of the annulus. That's really is the yeah, that's the part that you really want to separate.
Am I in the way or not?
Are you good? Yeah, exactly. Yeah. And again, you typically have a malleable underneath there that you can bang against, and then you know that you are, yep, keep going. that you are safe.
Tell me what I'm in.
Yeah. Yeah, just take the disc out. Yeah, just go right to the ALL. Discectomies are going to be done above and below. And it's going to be done on both sides. Okay, now do it on the, if you think it through. Yeah, nice. Okay, and let's do it on the top now. If there's more to take more. The ALL, really you got to take the outside of the annulus, otherwise it doesn't come out. Yeah. You got another pituitary? Yeah.
Okay.
Is there a bigger one than that? And you can feel, I sometimes put my finger underneath and I can feel it, how much of the ALL is actually being taken out.
I'm going all that.
All right.
So, Hudi, would you usually use these Z retractors or these spoon retractors that go around the front all the way to try to facilitate the resection of the ALL?
Yeah, so I put a malleable retractor that I can actually put against the pleura on either side. It's a wide speculum that will cover the disc space above and below. It cannot be too narrow. It has to cross the disc spaces so that you feel comfortable doing this discectomy and come all the way to the front. The hard part about this is really cut through the ALL right against where the vessels are. That's why you have to be careful with that. But when you have that big malleable underneath there, I don't have one here, but if you have one, then you can really, you feel comfortable with it. But anyway, we're taking the discs now on both sides. You can see.
Yeah, Dan has a comment here.
Hey, Udi, this is Dan here. And while you're working on these discs, I know it's tenacious disc, and so I wanted to make a comment.
Yeah.
Maybe you can comment about this too. One of the parts that I don't think I understood until I started doing a lot more of these is that dissection between the great vessels and the anterior vertebral body. There's a couple segmentals coming off the aorta and the vein.
Right.
And so when Udi says slide a malleable, that is the key maneuver to identify those. So whether you use a Yankauer or some kind of dissector, and you actually push the vessel's ventral, and then you see these little suspension wires between the spine and the great vessels. Those have to be clipped and cut very judiciously, because if you slide something, and you know the way that and just like my talk, we show this and slide your fingers in, dissect. If you dissect there and you avulse the vessel off the aorta vena cava, that's going to ruin your day.
Right, and
So,
you'll
yeah.
see the segmentals coming up right here, and you can easily take them. This is really a very wide corridor that you can see a lot through.
As long as your patient does not have a BMI of 40 or higher.
That's right. This is a perfect cadaver for that.
Now, whilst you're working so hard, let us keep peppering you with questions.
Yeah.
So, what do you do if you enter the pleural cavity at some point in time with one of your measures?
Right. So typically, no worries. As the thoracic surgeons will tell you, if it's a small opening, I'll just put a stitch through it. If it is to the point that you got a big opening that you cannot close, then a chest tube would be something that we will consider. But typically, if you really work at it, you can really push the pleura away to the sides. And if you create it's typically a small hole that you can correct immediately. I would just correct it immediately and not wait, because that hole tends to get bigger and bigger if you don't correct it immediately.
So you try to stitch the pleura, then do you tell the anesthesiologist, and do you put any small catheters into the pleura or anything like that, or?
No, again, if it's a small hole, I just correct it. I let the anesthesiologist know what happened. And I don't try to suck hair or anything like that.
Okay. The next question is, can you talk about braided saws again and some tips and tricks in terms of how to make sure that you use them safely? Obviously, a clear ventral passage space that is contiguous has been identified by Dan and by yourself, but what do you think of these braided saws, and what are some of the tips and tricks to minimize the risk to adjacent structures like that white tube that you're working around?
Yeah. So there are two ways of dealing with these wires. And actually, some companies have started looking at ways to use it safely with specialized retractors that fits underneath the spinal cord. But the bottom line is with these wires, you either go bottom up or you go, so either go bottom up, which means what I do sometimes is I put the wires from one side and pull it up from the other side. On the floor, identify the wire that I'm right against the disc space, and then slowly I will walk the wire coming through the anterior ALL, which is really the hard part of this resection. Once I'm through the ALL with the wire, I can then come with my pituitary forceps and come down to the area where the wire cut through the ALL. The other option is to start the discectomy from the posterior aspect, drive the wire underneath the spinal cord, drop it right into the disc space. Now that you've done your partial discectomy, let's say you took the posterior 1/3 of the disc, you can drop the wire into the disc space safely and then drive the wire all the way down. You kind of have to walk your thumbs on both ways and slowly kind of walk it back and forth until you come from the front. So I typically do a combination of the two. I see what gets easier. All I want to do ultimately is be able to go through the ALL in the front. I think that part right there where my finger is the hardest part to separate. And so I always will try to see if I can get the wire, and it actually works very well. I'll get the wire in here, and I'll start walking it and making sure that I'm right against the disc space with fluoroscopy. And it works very well. Once the ALL is cut, you can complete the rest of the discectomy without worry about the wire comes against the cord or anything like that with your pituitary forceps. Let's finish the discectomy here. Does that make sense, Jans?
Absolutely, thank you.
Yeah, I mean, I think the worry about it is that if you keep going with the way I see it, if you keep walking with the wires from the front and you're bringing it toward the back end, you always worry that it's going to piston into the canal. And obviously you're going to have something underneath there, but I just don't do it. I just use the wire to cut through the ALL in the front, and I finish the discectomy from the back end. And then I don't need to worry about the wire kind of pops into the canal.
I very much agree with that. Dan, any experiences with your saws whilst Ehud is working so hard?
Yeah, I completely agree with you, Udi. I think we've all kind of, we have convergent evolution with that, right? So some of us will say, well, you know what, I'm going to do as much discectomy as I can. And I think what happens is people have seen our wires, and whenever I do these courses, they go, so when do you put the wire in? And I think you're exactly right. I basically say the wire for me is I do as much discectomy as I can, as much AL resection as I can under direct vision. And if I can push down the pleura and use a punch to punch the AL, and if I can use a pituitary like you're using, and if there's something left, then the wire can be threaded safely. That might be the case. But I agree with maybe starting with the wire might be not a bad idea, because, as you said, when you pull that wire through and that segment becomes mobile and you're pulling it all towards the cord, that is where you have your heart in your it skips a beat. So some of us have tried things like passing the wire laterally, and there's a number of pulley systems that now have been created by individual surgeons, but also by industry, where the pulley forces the wire lateral. So when you pull, a specimen gets pulled laterally. If you have experience with those, use it. If you don't. I think it's whatever it takes to get that disc out freely and safely. Yeah.
There's a little bit of attachment right there.
I hope that all of you in the lab later will actually try this. It's a really challenging part of the procedure. And you see how hard Hudi, who's a master, who's done this hundreds of times, is working on safely mobilizing that vertebra.
You can see right here the body is very mobile. Again, you got to watch the spinal cord as this is done, clearly. But you can see how mobile this is now as you keep going through the discectomies. And again, what's the difficult part? It's the front. That's where the wire becomes very valuable, I think, where you break to the front aspect and you know that you have created that groove, and then really all you have to focus in is the back end. So I think we are almost ready here to remove this thing. See from your side, Peter?
I think I disconnected it on the side. How do you put it out?
We're all with you, Hudi. We're all cheering for you there.
All right. So you can see the body is almost coming out. And the spinal cord is,
Right now we see your hair. Yeah, okay.
yeah. So let's see if we can push it from here.
What instrument?
Just grab it. You can use a pituitary forceps or maybe even the axle. See if you can slowly mobilize it from around the spinal cord. And again, you want to make sure that the spinal cord is completely, yep. And then just, hold on. Yep. So you want to roll it, instead of just pulling it, you want to roll it over. Yeah. There's something else you can grab it with. Yeah, stick the pituitary. Go ahead. You still down? Okay. Go.
Do you sometimes use tongs? They're these specialized kind of tongs to hold the vertebra. Have you ever seen those?
No. I mean, this actually works very well. You can easily roll it. There could be still some, yeah, here we go. So kind of roll it around the spinal cord. You can put some traction on the spinal cord. There's still some attachment here.
There always is, isn't there?
There's always one little thread. Yeah. So let's just, yeah. Yep.
You like the tongs, right?
Yeah. Yeah.
Actually, one comment that, Udi, while you're working on that, because everyone thinks it's ready, but it's never ready, and he always needs to go a few more minutes in the cooker.
Here.
So, maybe it is ready.
Yeah.
So one thing that Jens said is using some kind of rigid tongs to pull it out, and I think that's reasonable because then it doesn't rotate. Another thing that I've never done, but I know Peter Varga in Hungary says he does this in some cases. Say there's one side that does not have tumor involved, he'll put a pedicle screw in that side. And then he uses the instrumentation that comes with your pedicle screw to rotate. This very move that he's rotating, you basically use it as a shoehorn, and you actually have full control of the vertebral body. I've never done it, but every time I hear him do it, I say, that's pretty slick, and apparently he does that regularly. So that's another option. Imagine having a pedicle screw with a shaft on this thing. It would come out easily.
Hold it like this. So here is the vertebrae.
That's what we should have used.
Yeah, that would have worked better. You can see there's always, as Dan mentioned, there's always something that attaches, but you can see the vertebral body out.
Okay, now you're on the spot, Hudi. Several audience members here want to have you address this. You've worked hard. You've done a beautiful job. There have been one or two little bumps against the cord that we all saw. And now you're getting your new motors, and you've lost your motors. They were intact before. What do you do right now? You've just pulled this out. So what's your next step?
So the first thing is to make sure that we perfuse the spinal cord. So I will make sure the anesthesiologists know that I want the mean arterial pressure to be between 80 and 90. I will give a dose of steroids. And then I will take a quick look with fluoroscopy to make sure that there was no misalignment, there was no subluxation, rotation, or something happened when it comes to dinging the spinal cord. I'll take a Woodson and check underneath the spinal cord, superiorly and inferiorly, to make sure that there's nothing dinging or pressing against the spinal cord. If the alignment is correct, there's no obvious compression over the spinal cord, with my Woodson feeling above and below, there's no hematoma or anything. I'll wait and see by giving the steroids and by maintaining the pressure what's happened. I'll recheck it again. And if everything is perfect, which means I don't see anything obvious here, then you have to assume that during the resection or during the removal, that the spinal cord has been dinged. And you've caused the injury to the spinal cord. But these are the steps that will go by to make sure, the key is to make sure that the spinal cord is not being kinked. And sometimes as you're focusing on the resection, there could be a little bit of a translation, and the lamina above or the lamina below is kinking the spinal cord. And if that is the case, you just do you just extend your laminectomy or you realign the spine to make sure that doesn't happen.
So we want you to put a cage in a second, but as you're getting ready to put a cage in, address the following questions also. So we've checked the blood pressure, the maps are above 80. We've made sure the hematocrit is above 30. We have made sure that the cord is not mechanically impinged, altered, over-distracted, etc.
Right.
What about steroids and what about hypothermia?
Yes, I do. I do give a loading dose of steroids, and hypothermia, I think, is also a reasonable option. And we discussed it with anesthesia at that point, and some will say that it's something that we should go ahead and do. I think it's actually a very good idea to do that.
So how do you do hypothermia? Give me some practical steps.
I actually have not done it, because I've not been in that situation that you are getting me through here, Jans. My patients didn't get to that point. I know the University of Miami, Mike Wang, these guys have done a lot of studies about that. I'm not sure as to the temperature. Typically, we do it for our trauma patients with spinal cord injuries. I'm not sure as to doing it and start doing it in the operating room during a case. I don't know if anybody else have experience with that.
Dan, what about cold saline? Giving it a cold saline bath. You want to have the cord cold, right? Not the body.
Yeah, I think it makes a lot of sense, Jens, for protection, kind of freezing people, whether it was for brain injury or spinal cord injury. I have not seen it play out empirically in spinal cord tumor operations. I will say that it's imperative, though, based on what you said, to have a consistent relationship with your monitoring people, because somehow I feel right before I do anything aggressive, they tell me the motors are out. So it's right before I start doing and they say it's out, and I say, what just happened? Well, the anesthesia just changed, and they gave they changed them. So I think it's really important that, as Udi said, before he gets to the scary part, maybe you've already said, I'm about to do something scary, let's check everything again, because it's very frustrating to have them change motors, which are fickle. But yet, with the tumors, I haven't seen cold stimulation.
And by that time, it's many hours into the case. It depends what it is. If the SSCPs are okay, but the motors are out, I'm not going to be as worried as if they tell me that the SSCPs are out and the motor are out. So as Dan says, I think it's really the relationship that you have with your monitoring people to know whether this is whether this is a false positive or not. Right. It's not unusual in these cases, as the case go by, that over time you start losing the motor, but typically the SSCPs stays okay.
All right, we have kind of limited time now. Would you be willing to talk us through your thoughts, just within 5 minutes if possible, on how to put the cage in, what you've done to kind of prepare for that, etc.?
So this is really the fun part of the case. The residents and the fellow love that portion. You've decompressed the cord, you got the vertebral body out, you slug through this, you sweat a lot, you got the discs out, and now really look at the nice corridor that's left here on the side. Can we get this cage any small? I can't put it. I want to close it, yeah. So I like to, when it comes to choice of a cage, again, it's a surgeon's choice. I like a large cage, a cage that about as much of the end plate as possible. I don't like small cages that have a chance to migrate into the vertebral body above and below. You have to kind of complete your discectomy and make sure that you have nice end plates on both sides of the vertebral bodies before you put the cage. And even though you took the vertebral body out and you did the discectomy, there's always a little bit of disc that's still left behind, and you can still see it right here. There's still a little disc that's left behind. And then the placement, so this is obviously too small of a cage. Can we get it smaller than that? And again, here we go. So this is, let's see if that can fit in there.
How much distraction does the cord tolerate in a situation like this, Hudi, without predictably dropping your neurophysiologic signals?
Yeah, so I think there's a few millimeter of distractions, even though I actually find that I don't need to distract the spinal cord. The cages that are available right now are such that you can put it a few millimeters smaller than the end plates, and then you can definitely extend it without any distraction to the spinal cord. But at time, when I'm a millimeter short, and this is the cage that I want to use, I think that few millimeter of distractions are okay. You just got to watch the spinal cord and make sure that the amount of distraction that you do is not too excessive. But typically, there's so much variability within the cages that are available that you can get the right cage without the distraction. In fact, the way I like to do these cases is that I leave the spine as is. I don't change anything about the alignment the temporary rod is sitting there and maintaining it as is throughout the case. And so you can see here, for example, this cage, if you can show the, let's look on the fluoroscopy. Can you bring the floor in here for a second?
Yeah, we'll need an overhead camera also. I would like to see how you maneuvered that around. Yeah.
Yeah,
Great.
so let's bring the floor in here. Can you bring the fluoroscopy here? And Peter is doing a good job here. Yeah. So again, this is a little bit of a smaller cage for this case. Typically, I will pick up a larger cage than that can occupy as much of the space as possible. So let's get an X-ray here. So you can see that we are kinked. So let's go ahead and straightening it up. On. Yeah. So if it is a small cage, I prefer to put it as much of an anterior as possible.
So now you're increasing the dead space within this cage, right? So do you put anything into this dead space hoping that it'll heal or fill with something meaningful other than fibroblasts?
Yeah, so once the cage is being extended, I will feel bone in the cage. There's always a space where you can pack the cage because there's an empty space there. And then I'll pack bone around the cage itself, laterally and sometimes even on top of the cage. And there's a lot of bone. Again, a lot of times this is... Oh, it's too short? Okay. On? Yeah, on. On? So that's as big of a cage we have? Okay, yeah. We don't have a cage that expands any further, but on? Kind of like, we can move it back a little bit. On?
Do you ever use PMMA around these cages to fill in the dead space? Or
No. Again, we'd like to get this fused, and sometimes if you really worry about fusion, sometimes we can get a vascularized rib from here, and we can drop it in there, adjacent to the cage itself. On.
Great. All right, I think we got the principle. So, Hudi, any final parting thoughts or observations?
I think that really, if there's one thing about this case, the critical points would be identify, as Dan mentioned, and I failed to mention in the beginning, the segmentals as you go down on either side, so make sure you take those out so you don't get into some bleeding. I like the finger-to-finger touch. Be able to get your finger, do a blunt dissections as we showed, all the way around. In essence, by putting your fingers underneath, you can actually feel, you can see right here, my finger is underneath, you'll be able to feel the disc above and below. I put the temporary rod there, I maintain the spine as is from beginning to an end. I don't do a lot of distraction during the case. And then when it comes to the cage that you choose, again, I think that the larger cage you can put that fills up the entire space, that would be the cage I would use. And then small compression at the end. Once the cage is there, drop the other cage on the other side and compress against the cage. And then tag on the cage itself. Make sure that the cage absolutely does not move. If you see any gap or any slight movement between the cage and the end plate, you either did not expand it enough, you may have not chose the right cage, it's too small. That cage, once it's there, should absolutely not move. And then pack bone all the way around the posterior construct.
Well, this was great. Thank you so much. I know this is hard work to do, but applause here. Thank you.
Okay, thank you.